Ladies and gentlemen, please welcome the Senior Vice President of Performance Improvement, Julie Cerese.
Good morning, everyone. Welcome to Orlando, Florida, and welcome to the 2015 UHC annual meeting. I'm really so happy to see so many of you here this morning. This is the first of the next 3 days, of which I think you will find to be incredible learning, sharing, and networking. Our meeting this year is called Advanced. Over the next 3 days, you're going to hear about game-changing technology, innovations, and creative solutions that can advance healthcare and patient outcomes. And whether it's reducing cost, improving operations, or clinical quality, advancing and achieving the best outcomes has been our mission and goal, walking along with you for many years. As you know, UHC has been focused on understanding the drivers of performance. And over the past 10 years, we've learned a lot. Beginning in 2005 with our seminal quality and accountability study, we identified critical success factors. Those included a shared sense of purpose, a defined leadership style, a focus on results, accountability, and collaboration. We've continued to study what drives organizational achievement, and later in 2010, we've studied the drivers of those that were able to actually excel, those organizations that were able to leap above others, and we found that the characteristics of top performance were actually very much the same. We've continued to study what drives good governance in our top performing organizations, how they achieve accountability and results in those top performing organizations. And now the work continues. This morning, we're going to advance our understanding about ambulatory care. I'm so happy today to have my colleagues Bob Brown, Shefali Ray, and David Levine with me today. They're going to be walking us through the rationale for this work. They're going to be telling us in detail about the measures, giving us some initial thoughts and impressions about what those data have told us and what the implications are for the future. So without further ado, I'd like to turn it over to Bob Brown. He's going to join me here on stage. I did want to mention to you that we will hold questions to the end of the presentations, and we have the opportunity to have you join us in the center, right at this mic, and ask your question from that microphone so everybody will be able to hear the question. So, Bob.
All right, thanks, Julie. All right, good morning, everyone. Well, I'm really excited to be here this morning. I just celebrated my 20th year anniversary at UHC. It's hard to believe. Time flies when you're having fun. And I've been working hard along with Shefali, Julie, and David for the better stretch of those 20 years in the space we're going to talk about this morning, the ambulatory enterprise. And it's really exciting to see this agenda, this space, and the hard work of our member organizations in the ambulatory setting really start to come into focus. And I think that this particular set of activities we're going to talk about is important for two reasons. One, it really means a lot to patients. It drives a lot of our patient care. And number two, it's very important to the health of our member health systems, and that the ambulatory enterprise and all that we do across the continuum really pulls together the whole value proposition we deliver to patients, to our communities, and to the country. Despite that, as you all know, we are living in very turbulent times when it comes to healthcare in general. And the ambulatory care enterprise is no exception in that regard. There are a number of changes going on in the industry, a heightened focus on complex chronic care. The majority of the healthcare spend in our country is on patients with multiple complex chronic conditions. I think that there's a silver lining to this for our membership, in that as we look at the data, academic medical centers are more than a step ahead of the community and other players with respect to how they're positioned and how they perform in caring for complex chronic patients. Secondly, there is a heightened focus on shifting from volume to value-based reimbursement, as we all know. Folks being linked for years now on the inpatient side of the business through the Core Measures program and other CMS value-based program payment initiatives. We're beginning to see those, more than beginning to, we are seeing those migrate to the physician practice setting and the ambulatory setting, with an increasing share of our reimbursement being placed at risk for performance on quality, as well as our ability to manage costs across the continuum. And we're going to shed some light on how our members are performing in those important areas as part of this study as well. Incidentally or coincidentally, this too is an area where I think the academic practice community is very well positioned to lead the market in practicing evidence-based care, following protocols and guidelines, and really doing what's best for patients and what's best for the pocketbook in terms of delivering very high-value, cost-efficient care. We're seeing more and more of the healthcare delivered in this country migrate from the inpatient to the ambulatory setting. Again, it's kind of a good thing when you think about it for patients. Procedures and services I never dreamt of being delivered in the ambulatory setting even just 5 or 10 years ago. Spinal procedures, bone marrow transplantation, you name it. We're seeing technology really rapidly escalate the migration of services across the continuum into the more convenient for patients and ideally more cost-effective setting of the ambulatory enterprise. That is a new game for us, and learning how to run a lot of these services in an efficient manner, how to price them and to compete in the market both on service and on price and value is a challenge. And our ranking metrics here, and as Shefali will share with you shortly, shed light on this important area as well. And then finally, there's an awful lot of action going on, as I just alluded to, with the focus on complex chronic care, value-based payment, the shift of services from the inpatient to the ambulatory setting, and the marketplace is not standing still. We see all kinds of entrepreneurs out there, whether it be the Minute Clinic or some of these new ventures, Therados, I believe I read about a couple of months ago, lab services potentially migrating to new venues. And these place pressures on the academic medical center community as well. We can't stand still and perform the way we have historically, although that's served us well over the years. We really need to stay focused on constantly improving across the continuum, but increasingly so in the ambulatory enterprise. Before we get into the mechanics of the ranking and talk about some of the early learnings from this activity, I think it's important to step back and reflect on the fact that patients are at the center of all this. This is why I come to work every day. This is what motivates us, I believe, in all that we do. And we have a tremendous opportunity again here to do well for our patients, their families, our communities, and the country. There are some big gaps, as we're going to hear about. Equity continues to be a challenge in healthcare. Access to care is incredibly clogged, and patients really need, demand, and deserve better in all of these areas. We're also seeing a shift in terms of how patients, their patient responsibility with respect to their share of the total cost of care. This one's challenging. I don't know that we've fully seen the end of the story play out on this one. The shift to high deductible health plans is, I don't know if it's quite fully played out yet, but we're seeing rapid escalation. Some projections are 40, 50% of people being on high deductible plans in just a matter of years. That dramatically changes the equation with respect to getting patients in and seeing that they follow through on all the care that they need to receive. And then finally, as we're looking at complex chronic care, we're challenged to really develop the infrastructure and the systems that expand beyond the inpatient enterprise to take care of all of the patient's needs. And really the key in seeing patients cared for effectively and to go on to lead healthy, productive lives spans into areas including physical, mental, and social needs. And those, importantly, a lot of those psychosocial elements of care now are getting the due attention and focus that I think they long so have deserved. So now it's time to measure performance. I'm going to quickly describe some of the high-level aspects of the ranking and study, and then Shefali is going to share with you how this all came together. We're then going to turn it over to David, who's going to share some high-level findings from this inaugural study as well. And I think I've sort of covered, these are just some factoids for you. Access to care. How many of you have had to wait longer than 3 weeks to see a specialist at an AMC or any doctor at an AMC? Quick show of hands. Everyone's kind of shy here, but access to care, incredibly constrained, wait times, not just in the 2, 3, 4 week range, but sometimes in the 7-week range. I learned recently of a patient who had received a diagnosis from one academic medical center, really kind of a scary situation, a terminal diagnosis with probably rapid onset and not a really pretty picture of the future for this individual. And they called around to try to find an appointment for a second opinion at another member in their local market. And the best they were offered was 7 weeks. So we have a patient who calls and says, I think I'm dying here. I have a really tough diagnosis that I'm dealing with, and the best we can do is 7 weeks. I think we certainly agree we can do better than that. When we look at access to equity with respect to access, and we're going to look at the differences in access we provide to Medicaid patients versus commercially insured patients, we exist in our social mission, our safety net mission is to care for all that come to our door. In this important area, I think we have work to do as well. The service we deliver to patients, and I really sound gloom and doom like the rain outside right now, but really to set the stage for our performance improvement opportunity. Sometimes we're our own worst enemy with respect to access and running our enterprise efficiently as we look at the data. As many as 1 in 20 patients, and new patients at that, who we really want to have come to our doorstep, have their visits canceled by their academic faculty physician because something came up, bump rates in the range of 5% or higher. We're flying our airplanes half full. Probably most of us flew here to Orlando. When you think about it, our airlines that bring us here, they understand what it takes to be successful, and that's a challenging industry as well. High fixed cost operation with planes, fuel, ground support crew, insurance, and all the folks behind the scenes that make things work. An airline can't be successful unless they have an average load of, I would say, 80 to 85%. And you've seen in the past 10 years or so, with all the focus on efficiency in that sector, that they're finally getting it right. In the ambulatory enterprise, we are far from that, as you all well know. And then we'll talk a little bit, and David, having formerly been the director of the emergency medicine department at Cook County, we'll talk about the ED, an important access point for ambulatory service, and another one where there's huge opportunity to drive performance improvement. So our study at a glance. We are very quantitative by nature here at UHC, and yet again here we've brought that to bear. So we have 40 metrics rolled up into 5 domains. You can see the data for this study have been sourced broadly from a number of initiatives at UHC, including the FPSC, the New Access Initiative, the Core Measures Database, the Operational Database, and we're also gathering data from CMS's GPRO QR/UR reports for the ranking. We were delighted that 46 member organizations stepped up to the plate to participate in this inaugural study. We realized that the goal is to have closer to 100%, but 60% in the first year we feel very, very excited about. And I want to thank all of you. Many of you really went above and beyond in providing the data, the insight, the know-how, serving on our steering committee and expert panels and developing these metrics. Really, this is your study, and we want to thank all of you for being with us every step of the way to bring this to fruition. We're very, very excited. I also want to thank Shefali Ray, who's sitting to my left here. I've worked with Shefali for 10 years, a little over 10 years now, and she is just a delight to work with. She has worked very intensely over the past year to bring this whole effort to life. As you will see, We're covering a variety of data sources, a variety of metrics. We needed to really rally the support and interest from a large number of members in both Shefali Ray and Jake Langley. Jake, if you could just stand up for a moment in the front of the room over here. Jake Langley, our manager of Ambulatory Care Solutions. Jake and Shefali were really the engine behind all of this activity. So with that, I'm going to hand it over to Shefali.
Thank you. So I wanted to take a little bit of time to walk you through the domains and the metrics and walk you through the methodology that we used for scoring performance in the first year. As many of you may have received your scorecards over the last couple of days, we know there's been a lot of excitement and buzz about the data and the information that's provided in there. And so hopefully this leaves you with some good solid information to start your journey with, and then Jake and I are going to be available throughout the course of the next few days to answer more specific questions. So as Bob had said, we had looked at performance for more than 40 metrics across 5 domains. And the domains of access and capacity management and throughput were really the lion's share of where we wanted to focus our efforts, just given the statistics and the information that Bob shared with you earlier. These 2 domains represented 60% of the overall performance. And as you can see, there are a lot of measures that are really focused on the care that we're giving to new patients, as well as how well we are using our existing space and our existing high-cost resources to provide the care. We focused our performance on really looking at the subspecialty areas. And so as you can see, there's one metric in particular that looks across all of the medical and surgical subspecialties, and then a number of metrics that really hone in on what we felt like were the 5 major drivers of activity within a health system. And when we looked at performance in those 5 areas, you can see them listed there: cardiology, GI, ENT, urology, and medical oncology. We felt like it was really important to focus on the care that was provided at the core AMC, or at the mothership, as we like to call it. So we honed in and really focused on the activity in specific metrics on performance that was provided at that primary clinic site for those 5 different areas. In addition to that, we felt like it was really important to start looking at the utilization of certain services, especially high-cost services. And so we introduced a high-cost imaging resource throughput metric based on the data out of the operational database to look at the utilization of both CT and MRI activity within the system. The next area that we looked at was around quality and efficiency, and as Bob said, there's a lot of activity happening at the national and state levels around looking at performance in terms of value that is provided to patients. And so the key areas that we looked at there really were focused around CMS's current value-based modifier program. And there were both hospitalization rate metrics for ambulatory care sensitive conditions, as well as total per capita cost metrics that are included in the existing physician value modifier program. And we believe that they'll be around for the next couple of years. In addition to that, these metrics are very likely to be introduced in CMS's new payment system, the merit-based incentive program, which will likely be introduced in 2018. So we felt like it was very important to focus on these areas versus some of the physician quality reporting measures, given the high visibility and continuation of these measures moving forward. In addition to that, as I'd mentioned earlier, we really wanted to focus on understanding performance for high-cost type services. And the utilization rates for CT, as many of you know, have gone up tremendously over the past 10 years. And we felt like this was a real opportunity to understand those utilization rates and focused on a specific cohort patient population. So we focused on patients that came into the ED for asymptomatic headache and wanted to track to see how many of them actually went on to get a CT of the head. And the results are actually very striking. The last 2 areas, which represent about 15% of the overall ranking, were around the continuum of care and equity. And the continuum of care really spans across so many different areas, but we felt it was really important to focus on the emergency services in this first study. We narrowed that down to really look at high utilization of the ED and look at potentially, not misuse necessarily, but care where it could have been provided in a more low-cost setting. So we focused on ED frequent flyers, those patients that actually came into the ED 4 or more times in a consecutive 12-month time period, and patients who were coming to the ED for low acute services, and these are things like dermatitis, other allergic types of reactions, things that they really could have gone to a minute clinic or urgent care setting for. And then in equity, as Bob described, we've seen some really striking data that illustrates some key differences in how we're providing access to care for certain patient populations. And I can imagine that over time, this particular area will continue to be further refined and improved with additional metrics. As many of you know, the real impetus for providing this type of study and ranking was because there aren't a lot of standard definitions and areas of measurement in this space nationally. And so this really provided us an opportunity to create standard definitions for things that seem really simple, like how do you measure new patient schedule lag? Do you use calendar days or business days? Or even things that are a little bit more complex in terms of what do you really define as low acute services? Do you include chest pain and other kinds of indications like that in that definition? And I think that's something that we should all be really proud of, and where we spent a lot of our effort in this first year was to be able to really create standardization and common definitions so that together we can start to really measure performance and make meaningful decisions to improve performance. In terms of the scoring methodology, we really wanted to make sure we were aligning with the legacy Q&A. And so what we did this year was for all metrics except for the equity domain, use the transformation methodology, which aligns with the exact same process that the legacy Q&A uses for scoring performance. So we went through metric by metric and provided a score of 1 through 8 based on the individual score and the distribution in terms of standard deviation from the mean. And then on the equity domain, we used the inequity differential of looking at the p-values, again, very similar to how we do that in the legacy Q&A. So I thought it would be helpful, just given that the scorecards have just been released, to walk you through how the scoring works and what that looks like in the actual scorecard. And this is a little bit different than what you may have seen in the legacy scorecards. So I'm going to start here at the domain level, and we're going to talk about the access to care domain, again, given just the importance and the weight of this area. So when it comes to the metric level, so in this case, the metric is new patient schedule lag. You can see that we measured performance for 5 different clinic types, and the performance and the scorings were provided at each of those 5 clinic levels. To come up with the overall score for that metric, what we did was take each of the submetric scores. So for this particular organization, they had 17 points available out of a possible of 40, and then multiply that by both the domain weight and the actual metric weight, which was 40% of the overall domain, to come up with that weighted score of 5.1%. Then for each of the metrics within a domain, we summed up the actual scores. So for this member's activity, you can see the weighted scores there equaled about 13.1%. We also included at the domain level what the top organization performed and what their score was, as well as the overall median score among the 46 organizations. And then we calculated the weighted score as an overall score, and this is where it aligns with what you may have seen with the legacy Q&A. So we took that 13.1%, divided it by the total amount of 30 points, and you can see that score for this organization is 43%, and then assigned a rank for every domain. And then for each of the domains, we provided a high-level scorecard to show you what your performance looked like. And so you can see all of those different values provided at the domain level. We also provided an overall score and rank for the organization, so that your weighted score value there in the top row is really a sum of the values below it. And then we also provided star rankings for every organization. And the methodology for the star rankings was pretty straightforward. We took the top 5 organizations and gave them 5 stars, the bottom 5 organizations and gave them 1 star, and then redistributed the remaining stars among the 36 organizations in the middle. So with that, I'm going to hand it over to David, who's going to give you a glimpse of the first year findings.
Thanks, Shefali. So what did we find in the first year? Bob alluded to some of the findings that we had already been tracking in our databases, but just giving you a deeper dive into what was there. And very similar to the traditional legacy Q&A for inpatients, the first year of the ambulatory study, very similar in that the performance in the first year, like in the legacy inpatient study, the scores overall are on the lower end. And we've seen growth of the scores in the inpatient over the 10 years, and we would expect the same for the ambulatory. In both cases, as Bob said, we had a really good uptake of 46 organizations in the ambulatory Q&A. When we started the inpatient traditional Q&A, we had 79 organizations. Now we're over 100. So again, a starting point and moving forward. I don't know if people all remember, but the traditional Q&A now has 5 domains, many more robust metrics, but really started only with 4 domains and 31 metrics. And we went, last year was the first year that we had more than 10 5-star winners in the traditional Q&A, but when the traditional Q&A started, we did have 5 top performers. So likewise, in the ambulatory Q&A, 46 organizations participated. We were able to start with 5 domains, which Shefali has taken you through. We started with 42 metrics, and again, identified 5 performers. But if you look at the graph, you see that the top score is in the 60%, and if you sort of put that on an A through D or F scale, no one did really well. But something to remember is that partly this is the first year, and secondly, the way that we transform the scores and that Shefali took you through, it's impossible to get into the 90s in the top scores, but there is definitely opportunity to grow. And as I alluded to, as you see over the time, although there's been some dips over time, from the first year of the traditional Q&A to now, the scores have trended up. And more importantly, the number of participants has trended up from 79 up to 102. Very, very similar if you've been tracking the curves in the inpatient Q&A. The curve for the ambulatory Q&A is very similar. You'd have to really blow this up even more, but it's a pretty tight spread from the bottom performers to the top performers. It's significant, but it's tight. We chose 5 for the 5 stars actually because there is a statistical break between number 5 and number 6. And there is a statistical break with the bottom 5. And then like the traditional Q&A, we equally distributed the mid-star ranges because the mid, very much like the traditional Q&A, has really, really tight. And like a couple different cases, a couple different data points off make a huge difference. Again, very similar to what we've seen in the past. Looking at the individual domains, we see spread in all the domains. These are a box and whiskers with the square box being the median and then the high and the low on the bars. With the exception of equity, where the median was 100%, and in general, although there were some people that did not do well in equity, and we'll get in more detail about equity in a little bit, the median for equity was very good. In the other areas, you see significant spread, but the areas that I'm going to focus most on are where our access to care and capacity and throughput. Because not only is there big spread, but as Bob alluded to in the beginning, there is definite opportunity for our ambulatory enterprises to perform significantly better on behalf of the patient. So some of the areas that jumped out, and we're going to dive into much more detail in a second, but we're really going to focus within the access to care area on that new patient visit scheduling lag. The fact that we can't get new patients into our specialty clinics in a timely manner really is problematic to patient care. It then makes patients have to go to the ED or seek alternative care, or their illnesses to continue to deteriorate before they get seen. As Bob talked about, we'll dive deeper into what we found in the bump rates, what we found in the CMS ARC quality indicators, which in general were good, but we still found a high range of difference between providers, and that scheduling lag. In the continuum of care, we're going to talk and dive deeper into the ED patients, and then we're going to talk about clinic capacity as well. So the biggest thing that we really found is timeliness to patient care and the cancellation rate. For over a third of the participants, only 1 in 5 patients was seen, new patients was seen within 7 days in cardiology, GI, and urology. As Bob sort of told that story, it wasn't in that specialty. New patients that are being referred with acute illnesses are not being seen in a timely manner in our clinics. And this is a problem for quality of care. It's a huge access problem. It's a huge patient satisfaction, patient experience issue. Almost worse is if you have to wait a long time to get appointments, and then you get an appointment, and then you're bumped, you're canceled because the physician can't see you on that day. And the highest areas of those bumps, cardiology and GI. So again, a patient waiting finally to get in to see the cardiologist, and then 20% of the time, the 20% of the cardiology clinics had a bump rate of over 7%. So you're waiting for this long appointment, and then on top of it, you're bumped, and then the wait just gets longer. These patients are forced to seek care, sometimes at competitors, but in a lot of cases, since we are the specialty providers, they're forced to go to the emergency department or to suffer with their conditions, possibly having a poorer outcome than if we had earlier intervention of testing or therapeutics. Same thing in GI. Actually, 50% of GI clinics had a bump rate of greater than 5%. You think about our frustration with the airlines, as Bob talked about, with the planes flying half full. How aggravating it is when your flight is canceled. And as bad as the airlines are, their cancellation rates are not as bad as our bump rates are in the clinics. But you can see within this, looking at the provider-initiated bump rate in cardiology, there is still a huge spread. So some places have got this down and are not bumping patients, where others are bumping patients a lot. So there is a solution. People have figured it out, but not enough people have figured it out. And actually, to that point, organizations seem to have consistent performance against clinics, across clinics with their bump rates. What I mean is that if you're not bumping patients in one clinic, you tend to not be bumping clinics in any of the clinics. So if you look at the lower green bars in general, the ones that are performing the best with the lowest bump rates are consistently the lowest across cardiology, ENT, GI, medical oncology, and urology. Whereas the ones that have problems, it seems to be systemic. So the higher bars on the left on each of those are consistently the worst, with the exception of med oncology, where it's still a poor performance. And this really speaks back to what is some of the secret sauce that we found that Julie started today's program with in the inpatient study. It really alludes to leadership, accountability, and really a systemic approach instead of a one-by-one approach in those institutions that have been successful. Moving on to capacity management and throughput, the plane's running half empty. UHC has set a threshold, a goal, that clinic utilization should be at 80%. 80% of the clinic space should be utilized. We found that participants meeting this capacity, this 80% capacity, varied between, in some cases, some of the members in the study never, ever hit the 80% capacity at all. To the best, only hit the capacity just under 40%, 39% of the time. Again, there's fixed costs, there's staff for those clinics, and we've already looked at that new patients are waiting a long time to get in, and then on top of it getting bumped, but yet the clinics are not being fully utilized, in fact, being very poorly utilized. best clinics that did the best, getting closest to that threshold, were urology. And that makes a lot of sense in that, sort of procedural based, little bit more focused problems in general. Actually, it surprised me that medical oncology actually ran their clinics the best of the group, next to urology. And that's actually good for a very high acuity set of patients. And going with this capacity management throughput, again, the patient's not getting in, not being able to be seen, when the clinics are running in a half-day session, some physicians are seeing as little as 2 patients in that half-day session. And the range does go up to 15 in that half-day session, and some of this is understandable depending on the role of the clinician and their other roles, but it really does speak to the fact that we're not maximizing those clinic days when the physician's supposed to be in the clinic to really see their full load of patients. Again, the areas that were better on encounters per physician per session were in ENT and urology. So we've seen significant opportunities to maximize the space, maximize the productivity of the clinicians, and if we were able to do that, our 7-day follow-up for new patients would improve, our bump rates would improve. And really what this really comes back down to is the center of Bob's slide earlier, it's about the patient. And this has direct implication to their quality of care and their satisfaction and being able to get them towards wellness. So some additional observations. We have actually found that our costs, our overall strong performance on national benchmarks were in CMS total cost per capita in the case. Yet if you think about it, if we're not seeing a lot of patients, or the maximum number of patients, and the sickest patients aren't getting in a timely manner, and we're going to jump into some of the ED measures in a second, this poor cost, this good cost that looks good may actually be false because the cost is being pushed into the inpatient arena when the patients are being admitted that are sicker later, or into other arenas where they're seeking care. And it actually may be due to not actually providing the highest level of cost. This is something that the highest level of care, that's giving a false sense of low cost because it's the lesser amount of care that they should be receiving. This is something that we'll want to look into further in the next year as we sort of study these findings further, but something to think about. It's good that we're at a low cost threshold, but we have to make sure we're providing the maximum appropriate care for the patients. And one of the areas that makes me think this is that there were opportunities in the hospitalization rate for ambulatory care sensitive conditions. These are patients that have been deemed by national metrics to be able to be treated in the ambulatory setting that are being admitted to our institutions. And if you think about how congested most of our academic medical centers are on the inpatient setting, it doesn't help to have these low acuity ambulatory care patients filling our inpatient beds. That's clogging our ED, that's affecting our length of stay, affecting our patient satisfaction and our overall national metrics. 60 out of 1,000 cases are admitted in these ambulatory care sensitive conditions that really could have received more appropriate ambulatory care. So we've got to really think about, how does this affect performance overall? Do we have the appropriate care protocols in our clinics to treat the appropriate people in the clinics, avoiding those unnecessary admissions? And some of this winds up being that if we have poor outpatient care access, the only default is going to be inpatient when they come in through the ED. I think we are stuck in, there we go. So moving on to the continuum of care, and our continuum of care, Shefali said, for this year, we really focused on the ED. We know that in the future that we're going to want to look more around the continuum of care as we're looking into ACOs and bundled payments and whatnot, but the ED is a good place to start. And actually we found that over 40% of our participants had an ED frequent flyer rate of above 10%. So that was more than 4 ED visits within a year. And actually this you would think possibly, well, it's just the self-pay patients or it's just the Medicaid patients, the patients that you would think maybe have the least chance of access. We actually found that this frequent flyer rate really occurred regardless of payer status. So even in people that had actually commercial insurance and good plans were overutilizing the ED. You all know that the ED wait times are a problem, and this came totally out again in the study where the median ED wait time for admitted patients was 401 minutes, which is significantly higher, over almost 100 minutes more than the national average of 308.9 minutes. 89% of our participants had a median ED time above the national average. This is a core measure. This is something that's publicly reported. You can say, hey, our patients are sicker and we have other issues and things should be risk adjusted better. But the fact of the matter is, this is what we're being measured on. This is our front door to our institutions, and we need to continue to find ways to unclog the ED. And this is really both a throughput issue on the hospital side, but it's also, if we're not taking care of the appropriate people in the ambulatory setting and keeping them out of the ED, it's also an ambulatory issue. It's really a continuum of care issue. Equity was interesting. Equity, a lot of people did well on, meaning that the same type of access was available regardless of commercial versus Medicaid status. We do two-tailed tests on these, just like we do on the inpatient test. And interestingly, the two-tailed statistical test was significant in both directions. In some cases, Medicaid patients actually had better access than commercial patients. And in other cases, it was commercial. What you'd more expect is, well, we're getting the commercial patients in at least because those are our paying customers and it's just the Medicaid patients. But really surprising to me was that we saw a significant number of places that actually had better access for Medicaid than commercial. I think that this speaks, the difference in the two-tailed is again to the fact that we need to have better accountability, better systems, and better consistency. And it's probably more a randomness than any kind of significant process that's put in place to take one set of patients over another set of patients. And that's why it falls on both ends of the spectrum. So what's next? All of you will learn who our top 5 performers were at Thursday's member celebration. All of you already have your scorecard. As Shefali said, Shefali and Jake will be available. There's sign-ups for if you want to go over your scorecard, learn more about your scorecard. They're taking appointments. As a reminder, similarly, those consultations are happening for the traditional inpatient quality and accountability study and for the supply chain excellence awards. So at the registration desk, there's a place to sign up for those consultations. Those will take place in the next couple days. Shefali and team will be hosting a webinar on Tuesday, October 6th, to go deeper into the results and the methodology than we've done today. We actually have the methodology documents all out and available to go over. And so that's sort of your next to-dos. Our next to-dos, it's taken a team to work on this. It's just like in the inpatient. We need to continue now to look at these results, evaluate the results further, refine the metrics with our member committees. We are going to be looking to expand future domains, future metrics, tweaking metrics to make sure that they continue to speak for where we feel that we all need to move in the ambulatory space. And then we need to make sure and continue to enhance and develop our tools, our existing tools like the FPSC, our FPSC quality and efficiency module, our access initiative, and our operational database to make sure that, just like we've done with the traditional Q&A, that you can start tracking your progress on a regular basis. And this isn't a one-year annual checkup. It is a really a chronic thing that we need to continue to monitor you on, that you're able to monitor where you're standing. We will need to work, and we will work on refining the tools that you're already using, that the tools speak to the scorecard. So really, in summary, access is really the key. I really think in looking and delving in the data that if we can fix access, we can reduce the ambulatory patients that shouldn't be in the hospital. We actually then will help decompress our ED. It'll help our inpatient flow. It will also be much, much better for the quality and outcomes of our patients. I think we have to be aware that possibly this may bump up our CMS total per capita cost if some of those costs are artificially shifted right now, and that's okay as long as it's under control and we're providing the appropriate care. ED throughput obviously is a significant opportunity for improvement, and especially our frequently admitted patients. We have found in a number of UHC studies that these are unique patient populations, and they come in about 3 or 4 different varieties, and the key is figuring out your frequently admitted patient type for your institution and making sure you have targeted care plans for those types of patients. Some inner city populations are very different than some of the rural populations in certain cases, and we've seen great success with our performance improvement teams on frequently admitted patients and improvement when one has targeted this unique patient population. It's generally a small group of patients, but they use up a ton of resources and are very disruptive to the flow of the ED. And then really maximizing running our clinics at the capacity that they're built to use, making sure that we're maximizing our physician time, that they have protected time to see the patients in their clinic time, and making sure that they're not bumping and canceling their patients at such a high rate that they're doing. This will improve patient satisfaction. Obviously now we are measuring, besides inpatient patient sat, ED patient satisfactions on the near horizon. We're already measuring ambulatory patient satisfaction. And really, at the end of the day, it'll affect readmission rates and clinical quality outcomes. One of the next things that we'll be looking at and studying is how do the winners of the ambulatory Q&A relate to the winners of the inpatient Q&A? Is there a secret sauce that's shared amongst and qualities that are shared? And that's something that, like we've done with the inpatient, we're going to study, what makes our high-performing institutions high performing. What is it in the leadership component, the accountability, the availability of data, and whatnot. We do have some offerings to support organizations on our ambulatory performance. There's 2 collaboratives coming up. Post-acute care for total joint replacement patients is in process now for the next month, and the complex medical home are in progress right now. Those are ones that you'll be able to have access to field briefs and all the information from, but there are a number of projects that will be coming in 2016 from our performance improvement team. Those should be announced shortly. We're just completing a study, a survey from members of their PI priority lists, and actually be solidifying the performance improvement priorities. As I said, we're going to study the characteristics of top performance, and through the course of this year, look for spotlights. We're going to be looking for the leaders in those individual domains and spotlight what they've done, and so that we all can learn together like we have on the inpatient side. It takes a team. We at UHC did not create the study alone. Actually, we've done this in concert with our Quality and Accountability Steering Committee. We actually expanded that Quality and Accountability Steering Committee from the traditional committee to add people with ambulatory expertise. And we will continue to expand and build, and without them, we could not have had this study. And it takes a large staff of UHC, a lot of my analytic team, and Bob and Shafali's team with Jake, and then our operational database team as well, to really bring this all together. I want to really thank you. We're going to open up for questions for any of us on the panel. I'm just going to ask people to use the center mic, and you can just queue up there and shoot questions at us. We have a little bit of time to be able to answer any kind of questions.
The ambulatory sensitive conditions were developed by AHRQ as a population-based metric for access. At least in my institution, I'm sure most, less than 50% of the patients admitted to my medical service are from providers affiliated with my institution. So how do you reconcile those two, or how do you take that into account?
Do you want me to take that one? Sure. So I think we're on that journey now. So we actually attempted to try and recreate those ambulatory care sensitive conditions and the ARC hospitalization rates using existing data that we had, and we were unable to align it with how CMS was looking at it. And so for this first year, given the time frame and where we were at, we said let's use the CMS-based measures, given that folks were looking at that nationally at that level, but I think that there's an opportunity for the organization to do that with the existing data that we have.
I do think it's an area that we will continue to look at. We're looking at additional data sources that we can pull in moving forward. It's that balance of timeliness data to make sure that these really reflect the patients we see versus what we have, and it is definitely an area that we want to continue to look at to make it representative. Well, I just want to, on behalf of my colleagues, I just want to thank all of you for joining us this morning. It's a marathon. We've been through the first sprint of this with the first study. What we've learned from the inpatient ambulatory Q&A has really driven performance improvement on the inpatient side. We look forward to this study evolving, growing, continuing to have even more meaningful measures moving forward and be a driver in the ambulatory space. UHC has been on this journey to really continue to expand and really give the robust information in the ambulatory world like we have in the inpatient world. And we see this as really igniter to moving that forward. So thank you all for coming, and enjoy the rest of the conference. I know there's a number of council meetings to follow. Thank you.